Okay, no. Hi everyone. I'm waiting for Dr. Nedd to come in and start the live. Hi everyone. Hi, how are you? Good morning everyone. So we're just gonna wait a couple more minutes. Hello. Okay. We're gonna start in a couple of minutes. We're connecting now, just to keep everybody understanding of what's going on. It's connecting. Hold on 1 second. Hi.
Hi there.
How are you?
Yes.
Hold on 1 second, everybody. It's connecting. Thank you for joining us this morning. Much appreciated. It's connecting. Thank you everybody for joining in. Much appreciated. We're just connecting now. Hi everyone. Hold on 1 second. Hi Dr. Nedd, I just sent you a request. Hopefully it works. So hold on 1 second. Thank you again for everybody coming in to the live. He's a neurologist and we're going to be discussing about the brain. Hi. Hello. Hold on 1 second. So we're going to be discussing about the brain and neurology, and I'm going to. Hi, how are you?
Hi.
How's everything?
We good.
Yeah, we're good. We're on. We're live.
We're live finally. Yeah.
Hi. So why don't you introduce yourself to everyone?
Okay. My name is Dr. Kester Nedd. I'm a neurologist practicing in Miami, Florida. I run a large clinic called the Design Neuroscience Center. and I've been in practice for quite a while. My primary focus is on persons with brain trauma. I also treat others with stroke and other neurological disability. I have, other than being trained as a neurologist, I'm trained in a field called neurological rehabilitation and also neurological trauma.
Awesome. That's amazing.
So, yes.
Yeah. So, okay. So, what are your thoughts on early preventions? Like, so you immediately have your event that the trauma, like, that caused the brain injury. What are
Yeah.
your thoughts on first getting therapy and programs so you get better? What are your thoughts on that?
Well, off the bat, excuse me, one of my principal focus in my practice, contrary to others, is that of early intervention. The traditional neurology focus on neurological trauma is that let's take a wait and see approach. What I've observed over the years of practice is that the brain is a very intelligent system.
Yes.
And it adapts habits that are often not helpful to the subject, especially when you take the wait and see approach, because many of the negative effects of or the symptoms are quite devastating to the person, and not only to the person but the environment, the society, their friends. And as a result, we develop certain compensatory habits that are not positive. So, for example, take a problem with panic attacks and anxiety. The longer you experience the negative effects like dizziness, vertigo, headaches, is the more avoidance, the more you would avoid engaging in activities. And when you disengage, what actually happens, it's a form of protection. But that form of protection actually puts you in a place where whenever you re-engage, you feel anxious. You develop a fear of failure. And oftentimes that's the negative outcome of late intervention. And those effects are even more difficult to treat than the actual injury itself.
Okay, so it's kind of like you have this injury and you kind of just have to go head on and fixing it rather than waiting it out and seeing, oh, maybe, these symptoms will, well, I'm sorry, what?
No, go ahead.
Yeah, like these symptoms will, oh, maybe stop being there after a while. No, you have to get it head on so you can fix them now rather than later.
Yeah.
Which is like, for me, when I had my accident, my mom was like, all right, we got to get you into program after program, therapy. Like the minute I woke up from a coma, it was, okay, let's start walking. They gave me a list of what I had to do for the day. And then even when I went home, they're like, okay, we're going to put you, my mom was like, and my dad my whole family were like, we're going to put you into a 3-month program, outpatient cognitive rehabilitation at Mount Sinai program. So I went there every day and I learned emotional regulation. I learned and I practiced my physical therapy as I was going there every day. So it was that early intervention really, really helped me. I may not have needed it then, but later on down the line, I still use like the little things that I was taught, like swaps, stop, is there a problem? What is the problem? Alternatives and options, pick and plan. Are you satisfied? So I took it all in at that time, but I applied it later on.
Well, interesting. There are two extremes. There are those who would say, okay, let's do the early intervention in this regard. But there's also another extreme where you want to instantly get back to the state you were in before.
Yeah.
And therefore, you try too hard. And there are times the brain is not ready. The brain is not prepared to take on what we want to allow the brain to do. And that's sometimes negative. And some people experience negative outcomes. So it's a balance. The idea of being able to know when to do what and to what extent do you push yourself.
Exactly.
That's a very important issue when considering brain injury.
Without a doubt. Okay, so this is kind of what is your view on marijuana and it helping healing the brain and seizures?
Well, this is a kind of a two-edged sword. The unfortunate issue with marijuana is that it's not been studied in double-blinded traditional controlled trials. So, and also the development of the pharmacological product has not been done in a way that we put other drugs, the process we put other drugs through.
Yes.
And all of the safety issues and all of those. So marijuana came from more recreational use, and we've found the value in terms of medical use. So for example, as a physician, I'm used to say, give you X number of milligrams of a drug, and I will anticipate this effect. We have what we call dose response curves that we're able to calculate. And so even for different humans, we're able to adjust the dose appropriately.
Yes.
The studies are now being done with marijuana. So the idea is that when you use marijuana, or even now that you have more companies out producing it, we hope that they will come up with more purified products and products that we understand how they react, because there are different types of marijuana products, as you know, some that act instantly, some that take a longer time to act.
Yeah.
Some that have more effects on the immune system, others that affect more on the brain. And so it's important to understand, first, the drug, second, the characteristics of the patient you're giving and what you're giving for. And then, of course, the safety profile.
Exactly.
So the challenge you have now is not that marijuana doesn't have value in the medical application. It's just that it's the pressure from the world and the community to release it without this type of scientific research has made it very difficult for us as scientists, as neuroscientists, to be able to appropriately prescribe it. How much should you give, and what frequency should you give it? All of those studies need to be done so that we could better elucidate. A number of my patients are on marijuana, and I have a number of my colleagues that treat with marijuana. I even refer my patients at times to get those services.
Yeah.
But the challenge is, on a long-term basis, one of the things I see in my practice for the patients that we have on marijuana is the variability in response. So sometimes you'll see great response, other times, and that happens with traditional medications also. But it's one of those things you have to have a lot of balance. And when you use it with other medications, we don't understand the drug-to-drug interaction. Because marijuana is a drug itself, even though we think, okay, it's a natural occurring product. But so are so many drugs that we purify and we measure in order to provide specific dosing. So clearly it has beneficial effects, but it also has negative effects. I have some patients that I treat that have negative effects from the use of marijuana, and sometimes we have to take them off, just like I have with other medications. So yes, in certain types of seizures, it might be.
Something happened where it lagged. So if you can continue.
Yes. So essentially, that's my take on marijuana. It has application, but when using in a medical setting, you must get an expert that understands both sides of the story, and you have to have a set reason to use it. Some of the benefits from the use of marijuana would be if you're on narcotics, high doses of narcotics, and you're trying to get off of it. Certainly marijuana does reduce the use. All right. For some people, it helps them with sleep. Others, it helps with anxiety. And some people that have the racing brain, so to speak, it does help. But there are other medications that we use for all of those. And so understanding when to use what critically important.
Definitely, definitely. And like you had mentioned, enough research for to apply it to these people that are going through, issues with, it could be pain, or they need to eat and they're not eating. So I feel like there should be more research involved, like you said. So can we go into your book? Why don't you explain a little bit about your book and the ideology behind it? And
So I wrote this book based on my many years of experience seeing and treating lots and lots of patients over the years. Um, the part of why I wrote the book was for the very first question that you ask is whether we should do early intervention or not. One of the major premise of the methods that I've created is what we call the BETH method, the Brain Hierarchical Evaluation and Treatment Method, is to encourage early intervention. And the second would be to understand the nature and the natural history that of brain injury. I've said this before, brain injury is a disorder that's looking for a home in our field. And it's hopefully we find that home soon. And part of the reason that brain injury has not been able to find a home is because in other diseases, we've studied the natural history of those diseases. And we understand all the different phases and stages, the severity. We've taken a multidimensional approach to it. Problem with the field of brain injury, we've not taken a multidimensional approach. We've taken a very linear approach. We haven't looked at all the different facets of it in a way of understanding where we are in the scheme of things. So, for example, a person with a mild injury versus a person with a severe injury, they're totally different in terms of how we treat them, how they evolve, what are the natural outcomes of those patients, and even how we socialize those patients together in a treatment setting. And on top of that, we need different experts that have qualifications in treating patients at different stages and different levels. Because it's not just one disease. And that is some of this is one of the challenges that we see. So I wrote this book first to sort of give a voice to people with brain injury. Because when you think about it, most people with brain injury, particularly in the severe forms, don't have the chance to vote. They have a hard time advocating for themselves, like children have the same issues. It's a problem in mental health. So the political environment, we don't have a loud enough voice so that the legislations that needs to be passed at times, the allocation of resources. And one of the other reasons I wrote it was my own experience working in the field of brain injury and to see how health administrators, other colleagues and doctors literally treat people with brain injury or the field of brain injury. There are so much biases against persons with brain injury in our society that until those issues become front and center, the real answers to the questions that still out there will not be realized. And so it's important that the medical community, the legal community, the political community, we all invest more time and resources in first understanding what occurs when someone suffers a trauma to the brain, how they evolve in terms of the recovery, and what are the critical elements that we need to bring to bear in order to solve the problems. People with brain injury themselves have a challenge understanding who they are and what they represent.
Yes.
So again, I wrote this to sort of give a voice to people with brain injury.
I just want to say I appreciate that. I appreciate that so much, because when I was going through it, when I, had my moments of, I was just so frustrated where there was nobody to speak to. So I was like, all right, I want to start a platform where I can talk to people who need a friend, just a friend to talk to, or to know what's going on, know the fatigue, the aphasia, the being able to have a conversation longer than 10 minutes and be able to get my point across quickly. Just to have an understanding of what it's like to be a brain injury survivor. And that's very, very hard. And there's not, the community is big because everybody has a brain, and some people have brain injuries, but it's not talked about. So I thank you for the book. And I thank you for discussing and learning and just wanting to learn and understand.
Well, one of the things I wanted to show, I'll show you the cover of the book,
Yes,
and I want to talk about that. I'll show you. If you look at the cover of the book, you see steps. It looks almost like a reverse pyramid with steps. And the whole concept of this book is to understand that the brain is a hierarchical structure. Okay?
Yeah.
Hierarchy, as you know, it ranks. If you go king, queen, Jack, you come down in order in a society. It's a kind of a pyramid, but I call it the reverse pyramid concept. And at the highest portion of that pyramid is where your most complex functions are located, what we call the higher cortical function. And then the lowest are the more reflex and repetitive subconscious or unconscious portions of the brain. The higher centers is what makes us human, what makes us interact with families and so forth. So one of the reasons, again, for writing this was to be able to bring forth this idea that the brain is injured in a hierarchical manner, and it recovers in the same way. And from a therapeutic standpoint, if we utilize this approach, at all times we could identify where we are in the natural history, in the cycle of injury and recovery. This is critical. I think clinicians sometimes fail to understand this, and even the patients and the family. So realistically, this would help us, this type of hierarchical understanding would help us know when you could go back to work, when you go back to play, what type of modalities you could implement in terms of medications or therapeutic modality, what we call the non-pharmacological modalities, to help that person heal. One of the challenges we have in the field of brain injury is that we introduce the wrong treatment at the time when the patient should be experiencing or receiving another form of treatment. We kind of have a shotgun approach to it. And the other idea is we treat all brain injury the same. And that is part of the challenge. So in writing the book, I tried to also create a sort of a hybrid between what a consumer would want to understand about the brain and what a professional would want to understand. Most of the books out there either address one or the other. It's, for example, you might write a book about the story about your experience, and clearly that's necessary for others experiencing it. But it's clearly a technical side that it's important for you as a consumer, as a person that's affected by this, to also understand, but in a way that it's not so filled with neurological terms and jargon that really complex things. Even for professionals, it's sometimes hard for them to understand. And I'll tell you this, a lot of the professionals who've read my book have said, oh my God, this is great that you've been able to bring this down to a level that we could also understand.
Yeah, so everybody, so like the mass can understand, and they don't have to have a dictionary next to them, like, wait, what's this word? What's this word? They can understand it in the context that it's given.
Well, also the stories, the stories in the book are quite fascinating. Some of them rather humorous, but it really tells about, what people experience in true life, illustrated the signs, the symptoms, some of the clinical issues. And again, this first book is about more of how you evaluate the patient. The next one I'm coming out with is dealing mostly with the treatment. In fact, I could not put all of this in one book. Yeah. It's so much material. That's why I decided to do a second book.
That's
and
awesome.
I'm working on that right now, more on the treatment modalities.
Definitely, and I would love to connect with you on the next book when it's ready and when you're ready to speak about it. So okay, you were talking about BHET, correct?
Yes.
The how do you know when So it's how do you know where to start in a sense? Like, so when you're first looking at a brain injury survivor and you're trying to help them, and where do you start? How do you know where to start? Do you look
So,
at symptoms?
and that's a critical question, and I'm happy that you hone in on that. Having experienced it yourself, I can imagine the frustration that you've experienced, and especially when you go from one clinician to the other. My
Uh,
patients always tell me, "I am so confused what to do,"
yeah.
because us as clinicians get confused, and where to start is critical. So, where to start begins with understanding where you are.
Mm.
If you know where you are, then it's easy to figure out where to start.
To navigate and to be like,
Exactly.
okay, X,
So,
Y, and Z.
exactly. So it's critically important in the early stage to understand and listen to the patient and listen to the family and others as to what are the most critical issues that are bothering the patient. What I find out, I've developed a kind of methodology to think of brain injury in terms of physical complaints, cognitive complaints, and adaptive, what we call neurobehavioral complaints. So physical complaints are headaches, dizziness, fatigue, all of those, and that trumps everything. If you're having a headache, you can't think. If you're dizzy and the world is spinning when you walk outside, you're going to avoid.
Yeah.
So a lot of times we don't spend enough times listening to what the patient is saying to us, and what they're experiencing, because sometimes I see this often. Patients, they're insisting we got to get neuropsychological testing, and we have to delineate all the cognitive problems. Well, if the person is having a headache, they're not going to be able to perform a neuropsychological
Yeah.
test. And obviously, if they're already getting OCD and panic attacks, we have to figure out why. Is it the dizziness? Is it the headaches? Is it the fear of going to sleep at nights because of the racing thoughts that's causing them to develop this panic attacks and those anxieties? What are the elements? What are the factors, physical factors that the patient's experiencing, either from a disruption of the brain cycles? So, for example, one of the things that brain injury does to us is that it disrupts the cycles, the brain cycles in our bodies. And when there's disruption in brain cycles, it disrupts our functionality. So, in terms of where to start, what I like to do is I start by carefully listening to what are the signs and the symptoms that the patient is reporting or the person's around them. So, symptoms are clearly what the patient reports. Signs are what we as clinicians discover when we evaluate the patient. So we start from there. And 80% of what you do and learn about the brain and a person with brain injury is what the patient tells you or the persons around them, so that you understand what they're going through. And based on that, it'll help guide you in terms of your assessment.
And exactly, and it'll also tell you what part of the brain is being affected. Like when we talk about memory, or we talk about I don't know, it could be anything, but it directs you to what part of the brain that is maybe not working or not working correctly. Correct?
Exactly. And
Yeah.
it also directs you to what adaptive behavior the person acquired over time. So I have patients that I look at them and I know they could walk, but they refuse to walk because they have the fear of falling. Okay. So I know immediately if I focus on pushing them to walk, they're not going to walk.
Yeah.
I have to deal with the fear that they have of walking.
And sometimes it's just that little, they need that little push to be like,
Exactly.
no, no more negative thoughts. You're no more negative connotations, no more negative period. You have to switch your mind into thinking you already are doing it. You already can do it. And that's part of my recovery. Seeing so many doctors, that was really difficult for me because I would be in a negative state, a negative mind state, like just
Mindset.
negative. I'm sorry, mindset. Yes, negative mindset where I'm just like, I can't do this. What are you talking about? I can't walk. And especially being in the hospital, surrounded by people who with brain injuries, but a lot of them stroke victims, stroke survivors, and them being very old and elderly and trying to do what I was doing, but I was younger. I was 17. So I don't know, just trying to remain positive throughout my recovery is vital to anybody going through anything, really. Mind over matter. It's simple as that. So I appreciate you speaking to your clients and letting them know, like, hey, you can walk, you can do what you think that you can't because of fear, and it's just crazy how that could dictate your life. Fear, which
Well,
is
fear is protective, but it also harms you. So
yes,
if you hurt yourself, you're going to avoid something because you don't want to get into that situation. So but also fear sometimes could also it protects, but it also could help.
exactly. And then okay, so I love how you said clinicians must resist the urge to do something because of the suffering reported by the patient. So
Yeah.
they're like, yeah. So it's like they're quick to want to help, but it's like sometimes when you're just quick to react and just do something like to just help, you're not maybe not helping in the best way in a
Mhm.
way.
Yes. Well, um, so in terms of the reaction you're saying,
Yeah.
clinicians, yeah. Well, if you have a patient in front of you and you in a place where, oh my God, I got to do something to help this patient. They're having really bad headaches. They're having emotional issues. The family's upset all the time. You want to do something. You really do. But if you don't have the experience and you don't have the qualifications and you haven't seen a patient like that before, the best thing to do is to refer them along, because sometimes what you think might be you doing to help them could actually hurt.
Yeah.
And one of the things I see among my first starting with my colleagues is that because we have the term neurology behind our names or psychiatry, we can't assume that we know how to treat a brain injury, because the truth is that most training programs where we are trained have very little exposure to persons with traumatic brain injury, particularly on the cognitive, the neurosurgeons have great experience. They go in to do an operation, they take the blood out, and they go to the ICU. But what happens after the neurobehavioral aspects? And so many patients in this type of situation find themselves on medications that they shouldn't be on, simply because we're treating them like a patient that has schizophrenia or psychiatric disorder of some kinds, when brain injury is a neurological disorder that has psychiatric manifestations. And it has totally different, sometimes we use some similar drugs, sometimes we use the same drugs, but maybe different dosing. So the real issue here in terms of uh, when to treat and having a qualified person know what to do is that um, we need to have a community of persons that we know in our society that's trained and qualified to treat people with brain injury. Unfortunately, one of the challenges we have is that there's not a lot of standardization in the communities that we have. Even here in Miami, where we're supposed to be a large brain injury, we have large brain injury centers.
Yeah.
It's very difficult to find people that work in a group or refer to each other that treat people with brain injury. I mean, there are some cities where you find that type of group, but generally we are very scattered in small groups. So you can find one person here that knows physical therapy, that knows about brain injury, but the other one knows more about sports and orthopedics. And
Yeah.
what you don't realize is that having the one that just knows orthopedic treat brain injury could have a negative effect. Or if you have a
Yeah.
psychiatrist that knows how to schizophrenia and other disorders, and you ask them to treat brain injury, it's a whole different disorder in that sense.
Exactly. And also, don't you think that demographics to have a play in it? Like your age, well, it's your basically it's your age. Just
Well, all demographics,
yeah,
that
yeah,
includes age, race, sex, your socioeconomic situation, what kind of job you have, your level of education
The
that you
stress.
had before the injury, whether you were a child, a teenager, adult, what's your biology in terms of your hormones.
There's so much that goes into
Oh
play.
my, it's just, that's why I say it's multidimensional.
Exactly.
You know, how severely injured you are, how disrupted your brain is. What's the mechanism of injury? Is it a bullet wound? Is it are you involved in a car accident? Did you fall from a swing? These are all factors that we must incorporate in this. And then how how fast did you get to treatment?
Exactly.
Were you in the field for a long time where your brain didn't get enough oxygen or blood supply? You know, so clearly where you live has a lot to do, you know, whether the EMS were trained, you know, the emergency medical management folks that are treating you, whether they were trained to manage you properly in the early stages. Or did you go to a trauma center versus an emergency room versus an urgent care center? So many factors are involved here in, you know, what the ultimate outcome of your brain injury would be. So clearly all these factors we consider when we see patients.
Yeah, definitely. And then to wrap it up, okay, speaking on the NFL, right, and us talking about mindset, and what are your thoughts about, okay, I'm sorry, a football player getting hit in the head, they obviously have signs of a brain injury, and them deciding, okay, I'm going to go back out and play. Like,
well,
what are your thoughts on that?
I have lots of thoughts on this. Because I was head of the sports medicine program at the University of Miami for more than almost 20 years. And I see a lot of football players who have been injured. I see them post-injury, at the time of injury, and years after from the effects they suffer.
Sorry.
It's a serious charge to we as physicians and professionals have in determining whether people should go back to play. And there are many sides to this story, and you need almost another session to discuss the complexity of this decision. On the one hand, sports has a tremendous value in a society, competitive sports at that. But things like, when should you allow a person to play, at what age? Those are questions. You know, to what degree of injuries should we allow someone to go back to play? My philosophy is that if you remain symptomatic, you should not play. And it's obviously symptomatic. And I'll also tell you, many patients that completely recover from brain injury have not really recovered in many sense. Why? Because when they get exposed to situations where there is stress, many a times the symptoms actually show themselves up. The dizziness, the vertigo, the panic attacks, the headaches, the problems falling asleep, they've been going fine all along. 1, 2, 3 years after, they get themselves into a situation to go on a Disney World and get on a swing. Or they may involve in another accident, or they may have a situation in their family, somebody dies, there's depression, there's anxiety, and all of those signs and symptoms show up again. So the question always is that, have you really truly recovered from that brain injury? And if we send you back to play and you get another injury on top of that, what's the outcome? So it's critically important for the clinician assessing those patients, clearly analyze. It's important for them to clearly analyze if that person has truly recovered, because what you don't want to do is to get another injury on an unrecovered patient, and in the setting where you send them back to play. In my book, the first story I told of a patient that had a condition called second impact syndrome was someone that went back to their sport without being properly cleared or improved from the injury, and they were cleared by the neurologist to go back to the sport, and then had another injury. And of course, the story in the book, the very lead story, tells about how this patient went through being in a coma for 1 year before waking up from that coma.
Like, I can't imagine being in a coma for a year. I was in it for a month and a half, and that was long enough for me. But knowing that they're putting their self at risk, knowing that, I feel like with TBI or just with the brain injury, I think you find ways around your symptoms or what happened to you, but I don't think you fully heal. Maybe I don't know, maybe a couple of years, or I don't know. But for me, I feel like you just find ways around it, and then you slowly heal as time goes on. What are your thoughts about that? Do you feel like you fully heal, or
Well, in fact, I just did a blog on the concussiontbi.com about this. Do you really heal? And do you are you cured ever from a brain injury? And you understanding just how the brain works, it's lots of connections, billions and billions of nerve cells that connect to each other. And when that organization is disrupted, it creates a sense of vulnerability. The brain has to learn new pathways, and it's not as efficient as what it learned before. So even though it works,
yeah,
that those pathways and those connections have certain levels of vulnerability. So when you expose them, they show themselves up as not being as strong as the original connections that were originally developed and formed.
were once there? Yes.
Yeah. So yes, your point was well taken. That many persons who have suffered TBI or concussion, while they may have improved to the point that they function and they're able to function in society, they do have some vulnerabilities that sometimes affect them in negative ways.
Wow. Okay. Last question. Sorry, there's so many questions. All right. I have on my right side, I have I think it's hemiparethesis, or I don't know if I'm saying it correctly.
Hemiparesis.
Parasis.
Yes. That means you have a weakness on that one side of the body.
Yes, and like I guess I still have the weakness, but it's constantly tingling at the tips of my fingers and the tips of my toes, and the sensation is like I can't, if I was to do the dishes and it was hot water, it would be scorching hot, or it would be freezing cold. It would be just off. So it's called hemiparesis.
Well, no, hemisensory loss that's the sensation, loss of sensation. But
Yeah.
what you're talking about is something called hyperesthesia. That means something appears more than it really is, simply.
Okay.
So while I would feel the normal, the water's hot, your brain is interpreting it as something as of discomfort.
Yes.
Okay,
Yeah.
so what happens is it's in your skin, in your body, you have these what call receptors. So they receive information. This is one of your senses from the periphery of your body, and it sends them to the brain. They have those receptors are connected to. They're mapped to very specific areas of the brain at different levels. The first level, the way you interpret pain, is an area called the thalamus, or sensory experience. There's a nucleus called the ventral posterior lateral nucleus, and that's the relay station where all these sensory phenomenon comes in. That's part of the input system, and then it relays it to the more higher structures where you interpret pain as to the type of pain or the type of sensation that you experience. Is it pain? Is it temperature? Is it light touch? Is it the touch at two different points? Vibration, position. So your brain has ways of interpreting all of those sensory experiences. What happens when there's injury, you can have injury at the input, right, where the message is traveling to the brain, at the point where it's processed at the first level, or at the secondary, at the tertiary, at the quaternary levels. You have different levels where it's interpreted. And then you have an output, which is what you experience. So depending on how the brain recovers, you may experience different type of output symptoms.
Got it.
So clearly what's going on with you is at some level in your brain, when sensory input goes in for temperature, your brain is interpreting it like something else. In other words, your brain is pulling the wrong drawer to interpret it.
Is there
Right?
any, yeah, no, I understand that. Is there any way where anything maybe I can think to change that output?
Absolutely. There are many, certainly there are pharmacologic and non-pharmacologic. As you would observe, when you're busy and you're occupied and your mind is not focused on that, many
Yeah.
times you don't even think that it exists.
Yeah. That's
Okay?
what happens.
So
Yeah, sorry, go on.
so one of the therapeutic modalities is how do you distract yourself? And because one of the things that the brain does, it gives things importance. And the more you pay attention to it, is the more important it becomes. And the more it bothers you. So sometimes learning how to not give that symptom importance is one way to recover from it.
Ah,
Okay? And it's a
I,
simple methodology. And
so
therapists
simple.
use that method to teach. But the more you pay attention to it, is the more it bothers you. And that's what the brain learns. Imagine it's a pathway. The brain has learned a pathway. And it says, anytime hot water touches your hands, here's what you should do, feel pain. And your brain automatically feels pain. Well, your brain tells your body it's painful. So it's an interpretation.
It's the story you tell yourself.
Exactly.
And how you can, if you're constantly, because there was a time in my, there was a time in my recovery where I would constantly tell myself I'm the victim. The brain injury is me. That's all it is. Like, that's all I am, is the brain injury. My symptoms, my limits. But then over time, people in my life, my boyfriend, my family, they would kind of have to put me back into gear and be like, no, you're not your brain injury. You are this person. You got mindset, and then recontrol, redirect, your path. And from there, just.
Well, I'll tell you, this is the kind of conversation that we need to have about brain injury. And not just from a doctor to a person with a brain injury, but also from brain injury, a person with a brain injury to another person with brain injury, and from a doctor to another colleague or another professional, so that we all understand, again, the concept of Beth method that I've introduced.
Yeah.
This method covers all of those concepts in terms of how do you interpret what the brain is doing at what time it's doing it. So every symptom that you come at us with, we need to explain to you and say, why is your brain or your body behaving in that way? And I find that it's so therapeutic. Once that person understands why, a lot of times I don't even have to give them a drug. They get better.
Exactly.
Because they understand why. And then they can heal. But when patients fail to understand why, it's very difficult to treat them.
Because they're just kind of going on this, going throughout life, not understanding, like you said, why is this happening? Now that I just understood that the input and the output of my right side, maybe I can not focus on it. And I've seen that before when I've dealt with it. I've just kind of kept myself busy doing something else, and then it goes away in my mind, and the pain goes away, or the uncomfortableness goes away, where I'm just like, okay, whatever, it's not there anymore. So I'm just like, whatever, and then it's no longer affecting me in a sense. So I just wanted to say thank you so much for taking the time out to have a conversation, and if okay with you, later on we can have more conversations and more lives discussing more topics about the brain.
I would love that.
Thank you so much.
I appreciate what you're doing, and I congratulate you.
Thank you so much. And thank you so much. Everybody get his book, Amazon. Check it out. I'll have the link below in the new post. And yeah, thank you.
So nice to speak with you.
Bye.
Thanks. Bye.
Bye.